Welcome back to our EMREE lecture series. I'm Dr. Ahmed Jamal Bek, and in this session we'll explore key psychiatric concepts and their practical significance, which are essential for your EMREE exam. Our focus will be on the most high-yield topics, ensuring you're well prepared for the exam. So before starting with the lecture, I would like to mention one thing for students who are preparing for the EMREE exam. So psychiatry is a huge subject, and I would like you to divide those different disorders into different categories. So as you can see here on this picture, we have many different disorders, starting with sleep disorders, childhood disorders, anxiety, psychotic, as well as mood disorders. And there are also many different other disorders, such as eating disorders and personality disorders. We're going to go through all of them and cover most of those disorders. In today's lecture, we're going to start with the mood disorder, also known as depressive disorders. There are six main things that I would like to go through, starting with major depressive disorder, depression due to a medical condition, atypical depression, pseudodementia, dysthymia, as well as cyclothymia, and we're going to finish the lecture with bipolar disorder. So I would like to define what is a major depressive disorder first. It's a mood disorder, characterized by persistent depressed mood and loss of interest or pleasure, which is known as anhedonia, for at least 2 weeks. This is also often accompanied by symptoms like sleep disturbances, appetite changes, and suicidal thoughts. To be able to diagnose the patient, there's a very well-known acronym which is known as CGE caps. So as you can see here, each letter corresponds to a certain symptom. So S is for sleep disturbances, I is for interest loss, G is for guilt, E is for energy loss, C is for concentration, A is for appetite changes, P is for psychomotor agitation, and S is for suicidal ideation. So the patient must have at least 5 out of those 9 symptoms, and those symptoms must be present for at least 2 weeks. And once this criteria is fulfilled, we can see that this patient is having a major depressive disorder. Also, other key features that I would like to point out: the symptom must also, or all symptoms must cause socio-occupational impairment, and this should not have any relation to a substance abuse or any other medical condition. And in regards to the diagnosis, the EMREE questions may not strictly follow the 5 to 9 criteria, so look for key indicators such as weight loss, sadness, and social withdrawal. A strong indicator in the psych vignette is weight loss, so look out for this and be aware of it, as well as terminal insomnia, which is common, and you can see that those patients may have reduced libido, but nocturnal erections will always remain intact. In regards to medication that can cause and contribute to the major depressive disorder, beta blockers such as propranolol can do this, so be aware of it also. You're going to see this in your clinical vignettes and during your exam day. In regards to treatment, the first line is always going to be an SSRI or a cognitive behavioral therapy. Don't worry in regards which one should you choose or go for. They're going to either list an SSRI or a cognitive behavioral therapy. So whichever you see first, just choose it. And in severe cases, an electroconvulsive therapy can also be used. So in regards to persistent depressive disorder, which is also known as dysthymia, you should be aware that at least 2 years of depressed mood without fulfilling major depressive criteria is needed to verify the diagnosis of the patient. So patient may have 2 or more of those following symptoms, such as hopelessness, decreased appetite, decreased energy, as well as decreased self-esteem and concentration. And those patients will also might present also with symptoms such as sleep problems. So having 2 or greater than those listed symptoms, as well as having at least 2 years of depressed mood, is needed to diagnose those patients. Now we're going to start with bipolar disorders. I'm going to define the disorder first. So it's a psychiatric condition marked by alternating episodes of mania or hypomania and depression, with periods of normal mood in between. It has a strong genetic component, and episodes can be triggered by factors such as sleep deprivation or stress. So there is also a very well-known mnemonic that is used across many different textbooks, so which is known as dig fast. So the D is for distractibility, I is for impulsivity, and G is for grandiosity, F is for flight of ideas, A is for activity increase, S is for sleep deficit, and T is for talkativeness. So you're gonna see all of those symptoms in a patient with bipolar disorder. So you should be aware of this. Try memorizing it so that you can use it during your exam to be able to diagnose the patient. So first, the bipolar disorder can be divided into two different types, which is bipolar 1 and bipolar 2. Before going or diving straight deep into them, I would like to talk about the difference between mania and hypomania. So mania is intensely elevated, expansive or irritable mood with impaired judgment. This usually lasts for more than 1 week, and it can cause socio-occupational dysfunction. So they will mention anywhere in the vignette that maybe a dentist is unable to go to the work. So you would know that the socio-occupational dysfunction is present with this patient. And it also may include psychotic features and often requires hospitalization because those patients may have an increased suicide risk. In regards to hypomania, elevated or irritable mood, but also one key thing or a key distinguishing factor is that it's milder than mania and it lasts for 4 days, but it does not cause a socio-occupational dysfunction. So they can mention a dentist continues working normally in the vignette. So you know immediately that they're not talking about mania, but they're talking about hypomania. And the patient won't have any psychotic features and they usually does not require any hospitalization. Now going back into the bipolar 1 and bipolar 2. So bipolar 1 is diagnosed if the patient has at least one manic episode with or without a depressive episode. And in regards to the bipolar 2, it can be diagnosed if the patient has at least one hypomanic episode with at least one major depressive disorder. The patient must never have a full-blown manic episode when diagnosing bipolar 2. So this is a key distinguishing factor to be aware of. So treatment in EMREE is lithium or valproic acid. So lithium can cause nephrogenic diabetes insipidus, hypothyroidism, tremor. It's also a teratogen, so it can cause an epicycle anomaly. Valproic acid causes neural tubule defects, tremor, as well as hepatotoxicity. So if the question gives you an increased liver function test as well as tremor, choose valproic acid over lithium. You should always be aware of the medication side effects so that you can treat the patient accordingly. So now going through the cyclothymic disorder. It's a milder form of bipolar disorder fluctuating between the mild depressive and hypomanic symptoms. Must last at least 2 years or even greater than this, with symptoms present at least half of the time with any remission lasting than at least lower than or equal to 2 months. So now we're going to talk about depression due to a medical condition. A very well-known thing that you're going to see during exam is hypothyroidism. It's an extremely important cause of low mood and apathy. Also, EMREE likes post-MI and cancer diagnosis as the cause of depression. So a question might give you a guy who has weight loss and is crying post-MI. The answer on EMREE is just going to be any form of an SSRI as the treatment for the patient. Atypical depression is characterized by hypersomnia, which is excessive sleep, and hyperphagia, which is increased appetite. So one thing to be able to diagnose atypical depression is the mood reactivity. So the mood improves with any positive event, unlike other types of depression where it remains persistently low. Treatment for this disorder is cognitive behavior therapy as well as SRI. MOIs are extremely effective in treating those patients, but they are reserved for resistant cases due to the risk of serotonin syndrome, which we're going to talk about in other lectures as well. So pseudodementia, it's not actually a true dementia, it's a cognitive decline due to depression commonly seen in elderly. Patients may struggle with memory and concentration but improve when promoting. So initially they'll be unable to draw a clock but completes it when encouraged to do so. And the MMS performance, which is the Mini Mental Status Exam, the performance is always going to be poor, especially in apathetic patients. They're going to recall 0 out of 3 objects after 5 minutes. Also look out for classic depression signs such as short, quiet responses, low mood, and lack of motivation to be able to differentiate. Lastly, I would like to talk about the risk factors for suicide death. So there is also a really well-known acronym, which is a sad person are more likely to die from suicide. So the S stands for the sex, which is male, so it's more common in male than females. The age as well. D is for depression. P is for previous attempt, which is the highest risk factor. Whenever they're asking you in a clinical vignette, what's the highest risk factor for this patient going through suicide, and they listed a previous attempt, you're always going to go for this as the answer for the question. Also, ethanol or a drug use, as well as psychosis, sickness, organized plan, no spouse or other social support, and also if they stated that they have intent of doing so in the future. So this wraps today's lecture on psychiatry. I hope this helped clarify essential concepts for your EMREE preparation. See you in the next lecture where we're going to dive into another important topic. Thank you.